All right, welcome back to the PMHNP Podcast. This is Dr. John Rossi with Clarity Education Systems and www.pmhnptesting.com. So today's podcast is going to be a little different. We're still going to focus on some high-yield concepts for the PMHNP certification exam. Remember, for those of you that are here and listening to this podcast, we dive into some high-yield areas. We don't go over everything because this isn't the right, arena for that. This is for you to maybe on your way home from work or in groups with people at work or at school to just open up a little bit more to explore those topics that maybe we can't touch fully in the review because it just takes too much time. But we only focus on some really high-yield areas. You'll want to go back into the seminars themselves and the practice exams in order to fully understand this content, so that way you have everything that you need in order to answer the questions appropriately on the exam. But these podcasts are here so that we can have an open dialogue, so that we can get beyond the classroom and really come together as professionals and nurse practitioners to build each other up, to put us in league with other organizations that have been around for a really long time and that have a vocal voice, because I believe that our voice needs to be larger. I believe that our voice needs to be stronger in order for us to go out and advocate for our patients and our families in a grander and larger way, okay? So this certification review topic today is going to be legislation. It's going to be about scope of practice. It's going to be about practicing to the full capabilities of our education level. So we're going to go over those key areas. We're going to look at licensure. We're going to look at accreditation. We're going to look at credentialing, and then how we use all of that in order to really use our role as nurse practitioners appropriately. And then after that, I do want to step on a soapbox a little bit, and I actually want to open up this topic to a larger audience, not specifically just to PMHNPs and students within the mental health realm, but I want to talk to nurse practitioners in general. I want to talk to nurse practitioner students in general, the family nurse practitioners, those studying end of life, those studying pediatrics, those that may be certified nurse anesthetists, those that may be nurse specialists. So this is a big group of people, okay? And one of the concepts that I want to really hit on here is in the seminars, we talk about the nurse practitioner role and responsibility of mentoring and education, right? And that we are supposed to hit the largest audience possible. And so that's what I'm going to attempt to do today. So this podcast alone reaches upwards to 200,000 downloads and listeners, okay? That's a pretty large population. So if you listen to this today and you think that you have, a fellow family nurse practitioner or other type of provider that could learn something, please share it with them so that we can all come together and have a larger voice. And at the end of our discussion about the PMHNP topics for the exam, that's when we're going to kind of approach this larger topic and larger. It is debatable, right? We're going to have people that listen to this that say, I don't agree with what's being said, but unfortunately, I can't really cater to that, because what we're going to talk about today are hard facts, are topic points that are derived from recent research and evidence-based understandings to support the role of a nurse practitioner in United States healthcare. Specifically, we're going to talk about the fact that 80% of the workforce in U.S. healthcare is made up by nurses and nurse practitioners. Now, when you have a group such as 80% of an organization or unified population like U.S. healthcare, there is no reason why we should not be more representative on boards within the hospital, as CEOs, as clinic administrators, as professors in the educational realm. We need to go beyond our master's degrees. We need to be getting those doctoral degrees, and we need to be sitting face to face, foot to foot with others that are trying to fix this fractured healthcare system. There's no question about it. Within the next 10 to 15 years, if we do not do something dramatic and drastic, U.S. healthcare is not going to be able to sustain itself. Those that need healthcare the most, those underserved populations, are not going to have it readily available because we're not going to be able to sustain it. I'm here to tell you today, it is my personal belief that nurse practitioners are the gap, are the backbone of fixing that particular problem. How do we fix U.S. healthcare? Well, we start with that large population of certified, qualified, and professional team members and individuals within the nurse practitioner role. And so we're going to talk a little bit about that. I'll hope that you share this with other NPs that may not be in, specifically mental health roles, because this is something that should be discussed. This is something that should be, kind of preached on the hilltops, if you will, about our responsibility to take on greater roles within the U.S. healthcare system. And in order for us to do that, we are going to have to step up. We're going to have to get out there and lobby. We're going to have to get out there and talk with legislators. If we don't have legislators in our areas that are standing up for what nurse practitioners can do, then it is your responsibility to fill that gap. Go out there and maybe you're going to be the next congressman or congresswoman. Maybe you're going to be that individual that goes and sits on those boards and sits on those committees and sits in those legislative seats in order to open up this world of nurse practitioner help. And so hopefully this will inspire you to become more involved in our ability to care for underserved and needed populations, and at the same time, just put us in the seats that we deserve to be in those boards, to be in those executive spots, to be more directors in the healthcare platforms. All right, so we're going to stop with that. I know I'm kind of preaching at this point. I don't mean to. It's just because I feel so passionate about the nurse practitioner's ability to fix a lot of the problems that we have in U.S. healthcare. And we are going to talk about that. But first, we want to dive into, the PMHNP and really just nurse practitioner topics that you all need to know in order to pass your certification exams. These topics today are not specific to PMHNPs. This is going to be covered on all of the certification exams out there because it's not just specific to one specialty care of practice. It applies to all areas of practice for nurse practitioners. So let's go ahead and dive in a little deeper into these legislative, into these state, federal level areas that we need to understand, and then go beyond that to understand how we practice, how we license, how we credential, and how we become active, full members within the healthcare system. All right, moving on to our first area here, we're going to discuss legislation and the scope of practice for nurse practitioners. And we're really going to focus on PMHNPs, but please understand that if you're not a PMHNP or studying for that, this can apply to your area of practice and specialty as well. So we're going to cover practice authority categories for NPs, okay, including psychiatric mental health nurse practitioners and beyond. We're going to review the three main categories, provide state examples based on 2025 data, and then include supporting evidence. So PMHNPs follow the same practice authority frameworks as all of these other specialty of cares like family nurse practitioners through prescribing authority for controlled substances relevant to mental health treatment. This may also involve additional state-specific requirements that we'll have to look at. So as of September 2025, and according to the American Association of Nurse Practitioners, there are 27 states that allow full practice authority. That does not include other areas like Washington, D.C., for example, that are territories or other distinctions other than an actual state within the union. Now, what do we understand about full practice authority? Now, in these states, and there's a long list, and you can access those on the AANP's website, but a nurse practitioner can evaluate and diagnose a patient. We can interpret tests, we can manage treatments, and we can prescribe medications independently under the State Board of Nursing. This allows PMHNPs to provide comprehensive mental health care without physician involvement. Now, states with full practice authority, the list is long. Please refer to that updated 2025 list. But evidence shows that these full practice states where we are practicing fully and independently, we can increase access 25 to 30% in underserved areas with improved outcomes for conditions like depression. There was a study in 2023 that found that there was no difference in care quality compared to physicians And we also saw a 15% lower cost. Now, recent legislation in places like Michigan, Alabama, Louisiana, South Carolina, and Wisconsin, they are showing progression towards full practice authority in 2025. Now, federal efforts such as the ICAN Act, these are seeking to align Medicare with state laws for services like home health orders. So what does that mean? That means this ICAN Act is legislation that is aimed at improving access to healthcare services by removing barriers for advanced practice registered nurses under Medicare and Medicaid. That's amazing. So this act seeks to enhance the quality of care, lower costs, and increase patient choice in, really looking at the rural areas in particular. So it proposes these type of reforms to allow nurses to practice to that full extent of their training and education, and that is going to help support more effective healthcare systems. All right, let's go ahead and move on to the reduced practice authority and what this means. So in these states, nurse practitioners can provide care, but law limits at least one area or element, such as requiring a collaborative agreement with physicians for prescribing, and that limitation drops them down to a reduced practice state. So this can affect how you, as a nurse practitioner, manages medications, for example, for mental health conditions. So states with reduced practice authority, the list isn't quite as long, and it's shrinking because they're moving over to the full practice state. You can again find those lists on the AANP's website. But I know recently Arkansas, for example, has moved to full practice authority that was previously on that reduced practice state, and it's evolving at this point in time because they're trying to figure out their state laws and how the State Board of Nursing is going to utilize it. But this is amazing for a state in the South like Arkansas to be making that move, where typically the American Medical Association has had such a strong hold. For them to now open up and allow this full practice state, it means we're making a lot of good progress, but it also means that we can't stop and rest on our laurels. We have to move forward in advancing this mission of full practice authority nationwide. Now, there was a study in 2024 that was associated with reduced authority with 18% longer wait times for mental health appointments. Outcomes remain comparable, right, with 85 to 90% readmission rates for depression. Now, legislative examples include bills in Mississippi for potential transitions for full practice authority for those numbers to come down and for accessibility to increase and wait times to decrease as nurse practitioners take on that full practice role. Now let's go into that restricted practice authority and the area that really kind of makes the hair on the back of my neck stand because it kind of upsets me here. But in these states, nurse practitioners require physician supervision or collaboration for aspects like diagnosing or prescribing. So this limits a PMHNP in independent mental health practice. Okay, states like California, Florida, Missouri, these are areas that are very common to this kind of debate between practice authorities. And so if you live in those areas, you know what I'm talking about, and you know where some of the restrictions lie, well, all restrictions lie, and you know how frustrating it can be as a certified and fully capable provider. Okay, so data has shown that 20 to 25% fewer NP-led clinics reside within these restricted states, with a 10% lower remission rate for conditions like bipolar disorder. So recent bills, like we see in Missouri and Georgia, these are trying to aim for expansions, but it's still very much a difficult it's a difficult landscape to live in. So as we summarize this all here, practice authority varies by state, impacting PMHNP certification and practice in general. So evidence fully supports full authority for better access and outcomes. All right, so this is what we have to get engaged with. This is where we need to step up and help our representatives within our states to understand what it means for us to practice fully and how this is going to in turn affect and improve the men and women and children that they serve in their districts, and that will then make their jobs better. It will help their position as an elected official, and just in general, we're going to improve the landscape all in all if we can go out and help really move this full practice state across the nation. All right, so now we're going to move on to talk about some other legislation and scope of practice areas. Specifically, we're going to discuss legislative and regulatory topics that are relevant to nurse practitioners, okay? So these topics are more important for us to understand so that we understand how state and national frameworks are going to shape practice in general. And that's what leads to certification and how we are able to deliver patient care within mental health settings. All right. So we're going to talk about those nurse state practice acts. So each state has legislation enacted as a nurse practice act, or what we call an NPA. This defines the scope of practice for nurses, and that's going to include nurse practitioners and PMHNPs. So an NPA outlines qualifications, authoritative and authorized activities that we can perform as nurse practitioners. It also identifies the limitations, such as limitations in diagnosing, treatment, and prescribing. So the State Board of Nursing, or what we call the BON, this enforces these acts through regulation, including licensure requirements and disciplinary processes for the PMHNP or the NP. Now, for PMHNPs, these NPAs, remember that's the Nurse Practice Act, they determine authority in mental health specific areas, like prescribing psychotropic medications or conducting psychiatric evaluations. Now, NPAs, they definitely vary by state, and an example would be in a full practice state like Arizona, an NPA allows NPs to practice independently. In restricted states like Florida, supervision is going to be fully required. So updates to NPAs occur through legislation. Now, as of 2025, states like Utah, they've started to amend their NPAs to expand authority for nurse practitioners. So you as the NP should review your state's NPA through the BON or the Board of Nursing website for compliance, but you also need to look at it as often as you can so that you can start identifying key areas where you feel you can step up and talk to the Board of Nursing and talk to legislators and talk to those that are lobbying for us to identify key areas where we can improve our already established NPAs. Just because we have an NPA in place doesn't mean that it shouldn't be relooked at and amended. And we can do that by becoming actively engaged in the process. All right, so the consensus model for APRN regulation, we do need to talk about that. So there's the consensus model for APRN regulation released in 2008 by the National Council of State Boards of Nursing, or the NCSBN, and other organizations, and this provided a framework for understanding advanced practice registered nursing. Because we needed to better understand the regulation across all of the states. So it focuses on licensure, accreditation, certification, and education. It's what we know as the LACE model, LACE model. And that helps to promote uniformity. It's really important for us to have uniformity across the United States. And this is a way that we can focus in on that and figure out where we stand and where we differ. So the key components of this LACE model or the consensus model is we use the title APRN across the roll. Recognition of 4 principles and 4 roles. We have a certified nurse practitioner or a CNP. We have a certified nurse midwife or a CNM. We have certified registered nurse anesthetists, also known as CRNAs. And then we have clinical nurse specialists or CNSs. Education is at a graduate level. We must maintain and we must have that graduate level of education. Then we have to maintain a national certification in a role and population focus, such as, for us, psychiatric mental health areas. And then there's independent practice and prescribing without physician oversight. So this is what that consensus model is really looking to establish. So the model aims to facilitate license portability and improve this access to care to everyone. Now, as of 2025, implementation varies based on the state. So many states have adopted these elements, but as we've learned today, full uniformity is incomplete, and that's what's leading to barriers in multi-state practicing. And that in and of itself is what's leading to many of the fractures that we see in U.S. healthcare. Now, progress includes the APRN Compact, which supports this licensure mobility through not, where we can see one state accepting the licensure of another state, but that has not been uniform, and many states are not participating in this APRN compact. So for PMHNPs, the model supports certification in the psychiatric mental health population focus. Now, let's take a look a little closer at the national versus state level authority. So national organizations like the American Association of Nurse Practitioners, or the AANP, and the NCSBN that we just talked about, they are all advocating for that standardized practices through models like the consensus model and policy recommendations. So please make sure you remember the consensus model. But healthcare licensure and scope of practice are regulated at the state level under the 10th Amendment, which states that each state board of nursing has to enforce the NPA. So this creates variation. For example, national guidelines recommend full practice authority, but states decide implementation. Federal laws, like those governing Medicare, can influence reimbursement, but do not override the state scope rules. So PMHNPs must adhere to state authority while following national certification standards. Can you see the conflict there? That's why this is such an important topic. That's why this is such an important area for you as a PMHNP and as an NP to get involved with. We shouldn't see these gaps in authority because it fractures our ability to practice. Now, state laws detail NP permissions. They vary by practice authority category, and these applies to PMHNPs within that mental health context. So in full practice states, we are going to be able to diagnose, treat independently, right? Reduced, again, just to review, collaboration or supervision. There's one area within that full practice realm that we can't do, and so that's what makes it reduced. And then finally, we have restricted, and that's what's going to require that you have complete supervision by a physician. Okay, so let's talk about what it means for prescribing authority and Schedule II drugs and how this comes into play. So again, prescribing is going to vary based on your state, with those full practice states allowing independent prescribing of all medications, and that includes your Schedule IIs. Okay, so your high abuse potential, things like amphetamines for ADHD. Now, in reduced states like for Kentucky, for example, collaboration is needed for those Schedule IIs. So restricted states like Texas, they are going to completely limit Schedule II authority. All right? And moving on to ordering the diagnostic tests. So full practice, we're able to order and then interpret the tests independently. So what does that mean? It just means that we order those studies to be completed, and then we take the information that is provided by the radiologist and the other qualified individuals. We don't interpret what they find, but we take their interpretations, and then we can implement that and plug that into our treatment planning and our diagnosing in order to frame this full picture of the patient and what they're experiencing. Again, we're not going to be the ones that look at the imaging and make those determinations and interpret that from the imaging itself, but we are going to receive that information and we're going to interpret based on the certified individuals and qualified individuals that we referred them to get that imaging done, and then we're going to make those interpretations into our care plans and how we're going to perform our interventions and make our diagnoses. Okay. In restricted and reduced states, this is going to require oversight in some areas, and that is going to help to hinder this comprehensive approach to care. Now, the ability to serve as a primary care provider. So in full practice states, NPs can serve that role, okay? Things like PCPs, right? When we type out PCP in our documentation, a primary care provider, that is available to full practice states. That's because they're managing overall care, and that includes mental health. In those other states, restrictions are going to apply. And then many Medicaid and Medicare programs, they recognize NPs as PCPs federally, but because of state governance, they are not recognized as PCPs. So many states mandate direct reimbursement by insurers, and that allows NPs to bill independently. As of 2025, federal changes in Medicare, okay, this physician fee schedule, support nurse practitioner reimbursement at least at an 85% physician rate. Now, state laws vary. So in full practice states, direct billing is standard, while other states may require that physician involvement. So the 2025 federal budget includes provisions enhancing Medicaid reimbursement, and we should all support that. So these topics are going to highlight how state-driven nature of NP practice really determines how healthcare is delivered within the state itself. Okay, so now let's move on to the nurse practitioner education. And this is really important because as we start to talk about the nurse practitioner role, we have to look at the level of education that they've received and also the level of, how many patients have they seen within their lifetime? How much supervision have they had over patient care? How much direct patient care have they been involved with? And why should that be relevant when we're talking about, nurse practitioners with their certain amount of hours compared to MDs or DOs that have all those residency hours? And how do we try to compare those areas? So nurse practitioner education begins with becoming a registered nurse, right? You have to be an RN. Now, candidates must complete an associate's degree in nursing or a Bachelor of Science degree in nursing, and that is even changing in a lot of states. They have to have at least a bachelor's degree from an accredited program, and they must pass the NCLEX, which is our national RN licensure exam. So for NP preparation, a graduate degree is required. Most programs are going to accept RNs with a BSN, though some do allow ADN prepared nurses to bridge via an RN to BSN pathway. So it doesn't mean you can't do it as an ADN, but you are going to have to bridge so that you fulfill those bachelor requirements before you can go on to the graduate level work. Now, a nurse practitioner education occurs at the master's, MSN, or doctoral DNP level. We can also talk about PhDs, so not in the clinical practice area, but in the education and research area as well. And this is all, again, being conducted through accredited programs across the United States. Now, an MSN program, it's really going to typically take anywhere between 2 to 3 years, and will include somewhere between 500 and 700 hours of clinical education and rotation. A DNP program takes, anywhere between 3 and 4 years, sometimes can go up to 6, depending on how slowly you're taking it. And this is going to require, at a minimum, 1,000 or more clinical hours. Now, the curriculum covers advanced pathophysiology, pharmacology, health assessment, and population-specific content. Now, for PMHNPs, programs focus on psychiatric assessment, psychopharmacology, therapy modalities, and care across the lifespan. Okay, so something that we call from birth to the grave, right? From the day that we're born to the day that we die, nurse practitioners in psychiatric care are going to be able to help. Now, as of 2025, the MSN remains the minimum for the entry-level NP practice in most states, but there is this push towards the DNP as a standard. This is led by organizations like the American Association of Colleges of Nurses, the AACN. This shift is put in place because it's aiming to enhance leadership and evidence-based practice skills, which I talked about at the beginning, and I fully support. And through full implementation, this has been delayed over the years because our initial targets just weren't being met. There was just problems in getting people in education, being able to pay for this, getting the programs to be able to make the change from MSN to DNP solely. Then we had pandemics that hit, so it just hasn't changed the current situation. So MSN, and then you can go on to become a DNP. At this point in time, it doesn't matter. Just get that graduate level work done so that way you can go out there and be an exceptional provider. So programs must be accredited by bodies like the Commission on Collegiate Nursing Education, or what's known as the CCEN, or Accreditation Commission for Education and Nursing, the ACEN. PMHNP programs often require at least 1 year of RN experience. However, that is very difficult to assess at this point because so many universities are waiving that requirement or don't even have it. And a lot of the schools for PMHNP, they want to see this preference for mental health nursing, or at least some type of mental health history or background before you get into the program. Now, the national guidelines for graduation. National guidelines for the nurse practitioner graduation, these are going to be outlined in this 2008 consensus model for the APRN regulation developed by the National Council of State Boards of Nursing and other organizations that kind of played a part. So this model standardizes licensure, accreditation, certification, and education. Remember, we talked about LACE before for the APRN. Now, it requires that graduate level education in one of 4 APN roles. We talked about the nurse practitioner. We talked about the nurse midwife, the nurse anesthetist, or the clinical nurse specialist. And it also specifies that it has to be population focused, such as psychiatric mental health for us. Now, the National Task Force on Quality Nurse Practitioner Education, or the NTF, provides standards for program quality, with the 6th edition released in 2022. So these include requirements for admission. So BSN with an RN license, it requires a certain curriculum, 500 plus clinical hours or 1,000 plus clinical hours, with the 3P courses, that pathophysiology, pharmacology, and physical assessment. They have to have faculty qualifications and evaluation methods that are standardized. Graduation is going to require meeting all of those standards and then demonstrating competency in diagnosing, treatment, and interprofessional collaboration. Now, for PMHNPs, guidelines emphasize competencies in mental health assessment, crisis intervention, and cultural sensitivity, and this is going to be aligned with the consensus model's population focus. That's why we so heavily focus on culture and suicide and things of that nature, because it's required of us within our model. Now, accrediting bodies like the CCNE, these are going to enforce even us as PMHNPs. Now, certification, this is going to validate entry-level competency. So now we're moving on to certification. What is it? This is that entry-level competency, and is required for licensure in all states. So for PMHNPs, 2 main certification bodies or certifying bodies are available: the American Nurses Credentialing Center, or the ANCC, and we now also have the American Academy of Nurse Practitioners Certification Board, or the AANPCB. So graduating from an accredited NP program, and then we submit the transcripts and we submit our RN license, we apply online, and we pay a fee. Usually this is anywhere between $300 or $400, but please keep an eye out online. They will often put out specials during certain times of the year. I typically see it sometime in the summer and then again around the holidays, so that fee can be cheaper. Now, eligibility requires completion of the 3P courses that we just talked about and those minimal clinical supervised hours. Now, the ANCC's PMHNP BC exam is 3.5 hours, 175 questions, of which 150 are scored, and it's going to cover areas of assessment, diagnosis, planning, implementation, and evaluation across the lifespan. The AANPCB's PMHNP exam, this is a competency-based, focusing on psychiatric mental health knowledge with similar content areas that we just discussed with the ANCC. Both are computerized, and they typically see a pass rate between 80 and 90 to 93%. Now, the AANP's exam is going to be shorter. It's going to also have a shorter time of 3 hours, 150 questions, of which 135 are going to have to be passed in order for you to become certified. Certification is usually and currently valid for 5 years. It's renewed via continued education anywhere, it just depends on the state and where you're at as far as the hours go. I've seen it, between 25, 75, 100 hours. And then you also have to have minimal practice hours. And this, again, is going to be determined by your state board of nursing. Credentialing. So credentialing, this is going to verify qualifications for practice in healthcare organizations, things like hospitals or clinics, and is separate from certification. It's going to ensure that compliance with standards for reimbursement and privileges are met. That's very different from certification. Certification is about entry-level competency. Credentialing is about being able to understand that they are qualified for practices in hospitals and clinics, and that it is about compliance with standards for reimbursement and privileges. So we submit applications with education transcripts, certification, RN, APRN licenses, malpractice history, references, and then background checks. And all of that is taken into account when performing your credentialing process. Now, verification is going to involve primary source checks. So we're going to contact the schools. We're going to look at the certifying bodies for these licensures, and then time frame is really kind of sparse. It can be anywhere between 30 days, 60 days to 120 days. Now, for PMHNPs, this is going to include confirming mental health nursing specific training, and renewal is typically seen between 1 to 2 years. All right, and finally, we're going to talk about licensing. So licensing grants legal authority to practice as an APRN and is state regulated. So after certification, so you graduate from your program, from a certified program and an accredited program, you're going to go and you're going to sit for your certification, okay? After you take the certification, you apply to the State Board of Nursing with proof of education, certification, RN license, and then you pay some fees. Some states do require criminal background checks, and some states may even require specific continuing education be met before licensing can be granted. So the process, again, is going to vary heavily by state. Full practice states are going to issue that independent license, while others require a collaborative agreement with the physician. Sometimes you have to pay. I've seen monthly fees for collaborating physicians anywhere between $500 and $1,500 a month. That's ridiculous. I'm going to talk about that here in just a minute and why I think that's ridiculous. But PMHNPs must specify their population of focus when they are licensing. Renewal is anywhere between 2 and 5 years, with continuing education between 20 and 50 hours, and they also often require practice hours depending on your state. So the APRN Compact does allow multi-state licensure in those participating states. You'll want to research whether or not you fall in to those participating states if you have more than one license. All right, so those are the steps that we take to ensure competent, regulated practice. You always need to consult the AANP, the ANCC, and your State Board of Nursing for resources that are specific to your graduation, your credentialing, your licensing, and your certification processes. All right, and that's going to end kind of our study for today. We go into depth areas within the seminars and also the live review conferences that we produce through the www.PMHNP testing program and the Clarity Education Systems that we have set up for your certification preparation. And now you should totally understand what that means, right? You've graduated, you are now seeking after that certification process, you have the hours, you've got everything that you need in order to now sit for that board, and that's where we're at right now. But in the seminars and in the conferences, we're going to dive deeper into those areas to make sure that you're fully prepared for questions about those specific areas. Okay, now we're going to dive into a different section. Again, this is going to be me stepping up onto my soapbox because I think it's really important as a nurse practitioner, as a doctorally prepared individual that has an education platform and has a national voice, right? 2 years ago, I wouldn't have said that. I wouldn't have said that I had a national voice, but today I absolutely do. I talk to people from all over the United States and its territories, have been in contact with universities and schools and legislators. And so I feel that it's really important for me, because this is such a specific review topic that we've gone over today, because it aligns with my views on full practice authority. It is now important for me to stand up and give you my views and my opinion, because I have the authority to do so, and this is an appropriate area for me to do it. If you agree with me on these areas, please share this information. This should be something that we are all lobbying and getting behind, because in order for us to become champions for quality healthcare, we have to be a part of this movement and this moment in the evolution of nursing practice across America. This is a moment and a movement that demands not just our attention, but our unyielding passion, our relentless drive, and our collective voice that's really roaring, right, through the halls of legislatures across the nation. I'm talking about urgent, unbreakable needs for ongoing lobbying and bold legislation to propel the forward momentum of full practice authority for every qualified, certified nurse practitioner in every single state. This isn't just policy, rhetoric, okay? This is a moral imperative, a fight for lives, a fight for communities that are often left behind for the very soul of accessible, compassionate care. We've seen progress. Yes, it's definitely there. We've clawed our way forward, and it's been difficult. But with so many states that are still lingering behind because of reduced practice and even shackled by that restricted practice, we cannot rest. Now, imagine the heartbreak of a rural mother in a restricted state driving hours for basic care for her local MP that they could have provided in that rural area if only the chains of outdated oversight had been broken. This is quite literally our call to arms. So let me hit you with the facts, okay? I want to support this as we move forward with facts and data-driven information, because this passion is fueled by evidence, not just emotion. You're going to hear the emotion in my voice, but this is about evidence. So study after study screams the benefits. When NPs gain full practice authority, patient access skyrockets, especially in underserved areas where physicians are scarce. We're talking about increased routine checkups. We're talking about soaring patient satisfaction scores. And we're talking about slashed healthcare costs. No more duplicative billing, no more unnecessary physician sign-offs that drain resources and delay care. Research shows that this full practice authority leads to lower overall spending through earlier detection of issues and more efficient service delivery. What's the outcome? Patients thrive. We see better quality of care, fewer disparities, and healthcare systems that are more resilient. As proven during crises like the COVID-19 era, when temporary FPA or full practice authority waivers expanded access to save lives. This just, it gets under my skin. We have states during the COVID era that said, don't worry about those restrictions. We're going to lift it right now, and we're going to give you full practice authority. Why would they do that if they didn't have complete confidence in full practice of nurse practitioners? I cannot fathom why any legislator or any law-abiding state could then put restrictions back on to nurse practitioners after COVID, knowing full well that they had full confidence in them to provide care during a national and worldwide crisis. Think about the emotional toll. Families in states without full practice authority face barriers that exacerbate chronic conditions. They widen healthcare inequities. And yes, it costs lives. I've heard stories from NPs on the front lines here, tears in their eyes as they describe turning away patients because of arbitrary red tape. This isn't abstract. It's human suffering we can end with smart, evidence-backed laws. But we also can't just stop at full practice authority alone. Okay, we must ignite a fire under every nurse practitioner to adhere to their education and make it a part of their pinnacle and core practice. We need others to move on beyond the master's level and become doctor of nursing practice, DNPs, or PhDs. Right now, while over 73,000 nurses have earned a DNP license through since this push of program began, it's just about 14% of advanced practice registered nurses that hold that type of degree. And of those that are actually practicing, the number is even way less. Less than 1% of all nurses with any doctoral education exists. So by 2025, the standard is shifting, all right? Entry-level MPs, they may need DNPs as we move forward, and that's for good reason. But this degree that equips this higher level of education is going to let you have research acumen. It's going to give you leadership savvy. It's going to give you clinical depth, and it's not just to treat. It's about transforming the system. So I want you to picture this, okay? More DNPs and PhDs stepping up, filling hospital boardrooms, director's chairs, and chief operator roles. Why? Because NPs in leadership bring patient-centered magic, prioritizing safety, quality, and ethics that boards desperately need. Studies show our presence boosts teamwork, it improves outcomes, and it drives innovative care models. From nursing homes to major hospitals, nurse practitioner leaders reduce costs, enhance this preventative care, and it also provides advocates that are fierce for the vulnerability of populations that are not being served appropriately. Yet, too few of us are there. Let's change that, right? Well, let's pursue those doctoral level degrees. Let's claim those seats. Let's shatter the glass ceilings that are holding back our profession. When greater than 80% of the population within the workforce is not heavily, represented in these boards and in these executive levels, we are doing ourselves a disservice. So this momentum doesn't happen by accident, right? It's forged through tireless lobbying. Organizations like the American Association of Nurse Practitioners are leading the charge, tracking bills, mobilizing grassroots campaigns, and sharing strategies across the states. We've seen victories in Utah, 2023, others following, but setbacks too, like failed bills in Mississippi, where opposition clings to outdated models. We need every nurse practitioner, every ally to stay informed, testify in hearings, and build coalitions with insurers, public health experts, and even more physician groups who see the win-win. We share our stories. These exhausted patients that we see day in and day out who finally get timely care because of full practice authority. The community clinic thriving under nurse practitioner independence. These narratives, backed by data, are going to move our mountains. This is our legacy, ladies and gentlemen, a nation where every nurse practitioner practices to their full potential, leading with heart and expertise. We're different than other providers, y'all. We practice this holistic care of mind, body, soul, and spirit medicine, all wrapped up into one, okay? Let's lobby louder, let's legislate smarter, and let's advance our degrees and seize those leadership roles. For the patients waiting for the future of nursing, let's make full practice authority a universal topic. All right? This is where we step up. This is where we fight for a healthier America. All right? This is where we delve deeper into the heart of transformation. Imagine a healthcare landscape where silos crumble, where nurse practitioners and physicians and physician associates and clinical nurse specialists and allied professions stand shoulder to shoulder, not as rivals bound by these archaic hierarchies, but as equal and unified interdisciplinary symphony. This is the promise of full practice authority. It's not a threat to collaboration, but it's an ultimate enabler. When providers are unleashed to practice at the pinnacle of their education, their training, and their expertise, magic happens. Patient outcomes soar, access expands like never before, and the fractured U.S. healthcare system begins to heal from within. Studies paint a vivid picture here. Nurse practitioner-led teams in full practice authority states, they deliver care that's equal or superior to physician-only models. With improved guideline adherence, fewer disparities, and enhanced processes that save lives and dollars. Think of the emotional weight lifted when a patient in a rural clinic receives seamless, timeless interventions from an NP collaborating fluidly, right, with physician specialists. So no more delays from needless oversight, no more turf wars being fueled by outdated American Medical Association, the AMA guidelines that prioritize control over care. Instead, we open source our knowledge, sharing insights in real-time huddles, interdisciplinary rounds, and digital platforms, all grounded in patient rights. Provider responsibilities, and evidence-driven discussions about care plans and interventions, no longer shackled by financial structures that pit us against each other. This is collaborative agreements that drain resources and stifle innovation. We foster trust, boost job satisfaction, and elevate care, primary care, mental health care, and beyond. I have witnessed those tears that I talked about earlier of frustrations from providers boxed in by restrictions, and the joy when this full practice bridge opens those gaps and closes off the gaps by bridging us together, allowing NPs to diagnose, prescribe, and lead alongside peers, repairing our broken system one collaborative victory at a time. Ladies and gentlemen, this isn't just data. It's destiny for a nation desperate for equitable, efficient healing. Let's not forget, to build this future, nurse practitioners must go the distance. We have to commit to excellence that matches our passion. We need every nurse practitioner to rack up as many practice hours as humanly possible, hundreds and thousands at a minimum. Honing in skills in real-world trenches where theory meets the raw pulse of patient needs. Enter residency programs where available. These structured havens are going to grow exponentially, okay? And we've seen a lot more of them developed since 2007, where we're transforming novices into confident powerhouses, boosting retention in primary care, slashing turnover, and igniting job satisfaction that keeps us in the fight. But we must demand more. Nurse practitioner programs revamped for rigor, prioritizing face-to-face interactions that forge unbreakable bonds, hands-on mastery, and interpersonal growth over the isolation of these online-only platforms. Now, research shows in-person learning sharpens academic performance, reduces distractions, and builds the empathy essential for our calling. While hybrids can bridge gaps, but never really replace the spark of direct mentorship. So we have to find a happy balance between online learning and real-world practical face-to-face education. Speaking of which, NPs rise as mentors. Do you hear me when I say this? If you've gone to one of my seminars or my conferences, you can hear the passion in my voice. You must rise to the occasion of being a mentor. The precepting shortage is a crisis nationwide. Students scramble for sites. They scramble because of the burden by payments to preceptors who should give back freely as we once received. Let's shatter this. Foster exceptional education through voluntary, community-driven rotations where seasoned nurse practitioners guide the next generation without financial barriers, paying forward the legacy of our profession. Imagine the pride in watching a mentee thrive, the ripple effect of underserved communities. This is how we ensure quality, accessible precepting, building on unbreakable chains of excellence. Nurse practitioners, everybody listening, the distance is long, but together we'll cross it with a fire in our hearts. I want you to hear the passion that is coming as I talk about these very real challenges and difficulties that we face across the United States. Okay? This is an opportunity for us to step up, for us to be mentors, for us to be lobbyists, for us to be legislators, for us to be providers, for us to be executives, for us to be on the boards of hospitals nationwide, and finally put ourselves in a position where we can practice to the full extent of our education and our abilities. I hope this gets you motivated for what can be. If you live in a restricted state, you got to fight for it, okay? If you live in a full practice authority state, you need to get online, get on the phone, go to those restricted states and help those nurses find out how to best put them in a position with their legislation to advance the full practice authority. Together, we can make a whole lot of difference within our nursing professions. Thank you for listening today. I know this one was a little more fiery, maybe a little more, purposeful in my intentions of spreading full practice authority and higher education levels across our profession. But it's just such an important topic, and I want to make sure that you understand how important you are in U.S. healthcare, how detrimental and how vital we are going to be in providing an opportunity for U.S. healthcare to be fixed and to become less fractured and, less focused on money and power and more focused on providing accessible care through quality interventions and through nurse practitioners and physicians and PAs that are all coming together to provide holistic, interdisciplinary care once and for all, for everyone. Now, to end this, what does all this mean? All this means we are doing everything that we can to answer the call and to fulfill the goals that have been set by Healthy People 2030. If you've been to the reviews, you understand what Healthy People 2030 is. And there's a lot that happens there as far as bridging that gap from equitable healthcare to solving crises and conditions and medical and psychological issues that have been around for too long. And how do we do that? How do we fulfill those goals and surpass Healthy People 2030? We become involved nurse practitioners across the nation. Thank you so much for listening today. I hope you're having a great time preparing for your certification exams. If you're beyond that and you're here because you're a supportive nurse practitioner, I hope that you're doing everything that you can to support those nurse practitioners below you, and you're giving them all of your expertise and your time and your hours, so that way you are providing a future that is worthy of our name of Advanced Practice Registered Nurses. Again, for Clarity Education Systems and www.pmhnptesting.com, this has been the PMHNP Podcast with Dr. John Rossi. Thank you for listening.